Today's speaker is Dr. Kenrick Cato. Some of you have collaborated with him and know him well. He's an assistant professor at Columbia School of Nursing. He's worked at NYP Health System as a surgical medical oncology staff nurse and an analyst in the IT department, working on projects to improve patient safety through clinical decision support. Dr. Cato's research focuses on mining health records data to support clinical decision-making. And his prior work includes NIH-funded research in health communication through mobile health platforms, shared decision-making in primary care settings, and data mining of health records. His current projects include automated data mining of patient records to discover patient characteristics often missed, and the development of predictive models for inpatient clinical deterioration. So thanks for being with us. I'll hand it off to you now.
Thank you so much. So welcome everyone. Thanks for taking the time out to attend this lecture. My name again is Kenrick Cato. I'm appointed both at the School of Nursing and also in the emergency department here at Columbia University Irving Medical Center. And what I'm going to talk to everyone today about is the CONCERN study. It's a study that I'm a multi-PI on with Sarah Rossetti at the department. She's at the Department of Biomedical Informatics. You might know her well. And I apologize to anyone who's seen some of this content about CONCERN, but I want to start off with just some background. And so I have no conflicts to report. So as I mentioned, I'm going to go through a background of the study, talk about our CONCERN early warning system, and what we've learned so far. Specifically, I think about racial bias in nursing workflow. So the CONCERN study, CONCERN stands for clinical decisions. It's a clinical decision support system, and it stands for communicating narrative concerns entered by registered nurses. And what you can see here is the team. This is a grant funded by the National Institute of Nursing Research. As I mentioned, Sarah and I are the PIs on this study. Patty Dykes is the site PI at Mass General Brigham. This is a multi-site study. So when I talk about the CONCERN system, you'll see we implemented it. It's been implemented both here at Columbia and also at Mass General Brigham. And I apologize for my dog. So a little bit of background. So Sarah and I started working on this project about 9.5 years ago, and what we were looking at at that point was we were thinking about preventable deaths in the inpatient setting, and mostly what you see these figures here. These are just estimates from studies that show that lots of folks die in the hospital every year, basically, and the research that we've done indicates that nurses, because they spend a lot of time with the patient, they're really good sensors for potential change in patient state. Additionally, and I'll show you some analysis we did a while ago, nurses will detect subtle changes in patient state, and then they will change their behavior. They'll increase their surveillance. So our study really capitalizes on this change in surveillance. And so CONCERN is really an early warning system. And it's what we're doing is we're looking at the pattern of change in nursing surveillance, mostly documentation. And we use that as a signal for a nurse's concern for deterioration in the patient state. What's interesting about CONCERN, and it's different than some of the other early warning systems, is we are actually modeling nursing expertise. We're not looking at the actual physiological changes in the patient. And so for us, nursing surveillance is a leading indicator as opposed to change in physiological state, which we consider a lagging indicator of deterioration. And it's as a nurse, I've had this experience where I notice a subtle change in patient state, And for me, I never saw it as expertise. And when we talk to nurses, they don't describe it as clinical expertise. They say there's something quote unquote up with the patient. But as I done this work almost decade, we recognize that it is an actual expertise that nurses develop to understand that a patient might be at risk for deterioration. And so what we're actually doing is we are leveraging the bias in nursing behavior. And so, I think for us, it's really important to point that out, that a nurse is using their expertise to behave differently towards certain patients. Clinicians have limited time, and so they have to use their expertise to decide which patients they're going to pay more attention to. And so that's actually what we're leveraging in this work. And so, this we can think of as the good type of bias, or the bias that we think is positive. There's the variables that we use are time varying, and there is that bias that we see in those data where there are certain things that nurses do at certain times of the day and on certain days. And so, for example, we know that nurses will take observations at roughly similar times during their shift, and it's usually related. They group things together, so you'll see, for example, medication administration and vital signs being taken around the same time. And so that distribution of behavior is also really informative, because, for example, if you see a nurse waking a patient up at 3 a.m. to take a vital, that's a strong signal that they're concerned for clinical deterioration. And so it's this bias that we leverage. And so Sarah and I, with some other folks in our team, we did an analysis that you see here on the right, published in 2013, where we wanted to quantify that signal and understand, to see if there was a real signal in nursing behavior. And so what we did was we took a number of patients and we looked at cardiac arrest, and we found that nurses, their behavior from a surveillance perspective, so it was things like vital signs being taken, notes being written, also comments in the vital signs. So in the flow sheet of the EMR, a nurse, if they take a vital sign, they can right-click and write a comment. Those numbers changed significantly for patients who had a cardiac event, sometimes 24 to 48 hours before the event. So it showed that nurses were increasing their surveillance before the event, 24 to 48 hours before the actual event. And so that was kind of the basis for us doing our modeling. And so the concern study, so we promised the NIH that we would do we had three aims. And so in aim 1, we promised the NIH that we would do natural language processing and machine learning on structured variables, mostly metadata, things like, when were observations being done, when were notes being written, what time were they written, how many were written. So we used those metadata. And then natural language processing, we actually look into notes and comments, and we did some side work where we took nurses both at Mass General Brigham, nurses at Mass General Brigham and at Columbia, and we said, what are the concepts that you would find in a note that would be concerning for deterioration? We took a standardized terminology called the CCC that we mapped it to, and the CCC map, and that's a terminology for nursing concepts, and that maps to SNOMED. And we ended up identifying through machine learning 30 some odd concerning concepts. And so those features, along with the structured features, ended up going into our model to predict risk for deterioration. And we were looking we were trying to detect deterioration in the next 12 hours or the next 24 hours. Our definition of deterioration is a composite definition. So we look at whether a person had a cardiac event, had died in the hospital, inpatient mortality, if there was a rapid response called for them, or if they're in the med-surg unit, if they were transferred to the ICU, and that's considered unexpected transfer to the ICU. And so those are composite events for deterioration. They all roll up. So if one of those things happened in the next 24 hours. And then excuse me, we then in AIM-2 applied user-centered design iteratively to design the front-end app that I'll show you in a second, or dashboard. And then finally, we have implemented a randomized control trial to see if the use of that concerned app will affect some of our major outcomes. And our major outcomes are inpatient mortality and length of stay. And then we have some secondary outcomes. Before I move on, I want to point out that the main goal of our whole intervention is actually not to predict deterioration. It's actually to improve interpersonal, interdisciplinary communication. Sarah and I came to this work from different perspectives, but both of us were interested in how nursing expertise is communicated to the rest of the world. And we strongly believe that to improve outcomes, what needs to happen is for clinicians to talk more effectively, communicate more effectively in the interdisciplinary team. And so the Concern Project is really designed to surface the nurse's concern for deterioration so that there could be a conversation through the whole interdisciplinary team about a patient's individual risk for deterioration. So after both focus groups and our modeling approach is one that goes from the expert back to the data. And so so we did focus groups with clinicians, and then we looked at features that we thought were good features for modeling nursing expertise. And so this ended up being kind of the large buckets of features that we use. Underneath this is, we've in the feature engineering, we slice these buckets up into sub features. But basically, as I mentioned, we're looking at vital sign entry frequency. We're looking at vital sign comment frequency, medication administration record frequency. We found that there is a strong signal in if a nurse decides to withhold a medication, or if a nurse decides to give a non-regularly scheduled medication or a PRN medication, as needed medication. Part of a nurse's job is to decide. So a clinician will order a medication. But part of a nurse's job is to decide when that medication is scheduled, if it's appropriate for the patient at that time based on their clinical state. And so we see that if a nurse is withholding a medication, then a nurse is concerned that that medication should not be given. And so that's a strong signal. And then node frequency, and then I mentioned we're doing NLP on the nodes to find concerning concepts, and we also use demographic information. So we ended up doing modeling using a number of learning algorithms. We did a basic generalized linear model. We used XGBoost for gradient boosted machine learning. We also did just a generic random forest model as well. This is just some metrics from our best performing model. when we adjusted some of the thresholds. I think it's important to point out that that we actually have two models that are running underneath the dashboard. One is an ICU model and one's a acute care model or med-surg model. It was important to build two separate models because the clinical workflow and the healthcare process is different in the two settings. And so we actually have two different models that they're running. And so there is a backend that we have built. Everything is built in Python, and we're using Airflow to Apache Airflow to do the scheduling and the work, the process. The pipeline is implemented in Airflow. And so we're pulling in every hour, we're pulling in these features, and then we're scaling it and then creating a prediction for the risk for deterioration. And that prediction, we generate a number, but it's actually shown to the clinicians as green, yellow, or red. And with green being low risk of deterioration, yellow being moderate risk, and red being increased risk of deterioration. So this is what it looks like. We have it implemented in Epic. We have Epic both here and up at Mass General Brigham. We have a concern score column that shows the icon. The icon is updated every hour, possibly. There's an asterisk here if there's been a change in the previous levels. So, for example, you see here asterisk in some of these. It means that for this green patient, previously they were not green, so they might have been yellow or red. And so this is just to show the clinician when they're looking at their patient list really quickly that there has been a change. We actually had visualized, or in our brains, we thought we were going to do an interruptive alert for concern. But when we did our focus group testing in the iterative design, clinicians said, please, 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 and this was with both physicians and nurses. They said they did not want another interruptive alert. And they also told us that they did not want a score. They wanted colors. They wanted risk levels. And so that's why you see the risk levels. We ended up generating a score anyway because it helps with trending. And so if you're a clinician and you're looking at, and then the last piece is in the focus groups, we wanted to figure out where in the clinical workflow to actually implement this. And so the patient list was a place that both physicians and nurses felt was central to their workflow. So say you're in your patient list and you see a patient's red and you want to learn more, you click on the icon and it would bring to this is our front end app, which is a Smart on Fire app. It's basically, so basically what this app is doing when you launch it, it's using Fire calls to pull all of this information into the app. And so it's got in the banner, it's got the usual information that you'll see for anything in the EHR, so it's the right patient. And then it has trending information, so you can actually see what the concern score has been over time, and you can go all the way back to 72 hours ago. There's some other stuff you can, watch a little video, review our research, just links to PDFs of our previous research. And then if you click the model, it actually shows you where this patient is in the distribution of patients in the hospital at the time with their concern level. And we break it between ICU patients and med-surg patients. So if this is an ICU patient, it would just look at the distribution of ICU patients. And so finally, kind of the star of the show in the center here is the factors pane. We put this here for a couple of reasons. So one of the things that clinicians obviously wanted to know from a credibility and understandability standpoint is what's driving an individual concern score at any given time. And so through focus group testing, we came up with this approach, working also with the graphic designer. So each of these buttons is the different factors, and we've kind of stuffed the variables or the features into these buckets of factors. And we're doing what's called what if analysis to see which of these kind of large buckets are contributing to the score. And then this gray line will show the magnitude of how that's contributing. It doesn't show the direction because we found that to be too complicated to try to indicate, but it shows the magnitude. And then you can click on each of these and it'll give a chronological list. So this, for example, is a medication administration record. One of the things that's interesting is the clinicians always ask for this because it's hard, believe it or not, it's hard for a physician, for example, to know what was given to the patient. They know what they ordered, but they don't know what was given. And so this is a way that they can see the relevant, the contextual information about concern without going to other parts of the EMR. This is also, this provides common ground for clinicians to have a conversation about the concern level. So nurses and physicians can talk about, hey, this is why a patient might be at risk for deterioration. And it's rationalized out through these buckets so that there's a common ground for interdisciplinary communication. And the nurses love it because they now have something that they can talk to clinicians about instead of saying, I just had this feeling and I want you to pay more attention to the patient. And then up in Mass General Brigham, we also created in the nursing manager dashboard, the nurse managers wanted a running total of the different, on each unit, how many patients were at different levels. This is implemented in Mass General Brigham, but it's not implemented here at Columbia. So mentioned user-centered design, talked about the levels and how important the levels were. And just one main thing I want to say about the levels is that when we were optimizing the thresholds for the underlying model, there were decisions. We used an approach where we had it was basically a simulation approach where we took real patients, mocked up their charts, and then we said to clinicians, what would you score this patient? Like, is this patient a green, yellow, or red? And what clinicians told us is they wanted us to optimize our thresholds so that we would have mostly yellow patients, or identify the medium patients, because from a clinician standpoint, they could easily identify the green patients and the red patients, but they felt that concern would be most helpful if we could maximize these patients at medium risk. So I'm going to switch gears a little bit here to talk about some of the things that we learned when it comes to bias in these data. So as I mentioned before, we're basically trying to model clinician behavior. And when we were doing our quality checks in these data, we did a couple of different analyses. And when we were doing those quality checks, we found that there is, one of the things we were concerned about was racial, gender, and ethnic bias in these data. And so I'm going to speak just about some of the things we learned about racial bias. So we learned that there is bias in nursing surveillance. We also learned that your modeling approach matters. There's also bias in early warning scores as well. And finally, that you need to adjust for this in your modeling, and we did that. So the first thing I'll mention is just, I'll talk about what we did around looking at the modeling. So the the visualization graphic that you see here, I'll just orient you to it. So in each one of these columns are about 9 models that we ran using different statistical learning algorithms. So XGBoost, linear model, and random forest. And what we wanted to know was we were looking at how these models were dealing with the relationship between race and concern scoring. So what we did was we looked at the total variation, or the difference in the probability between, so each of this is probability between proportion 1 and proportion 2. And proportion 1 is a measure induced by the race of a patient who experienced an outcome. And proportion 2 is a measure of a race induced by a patient that the model predicted would experience an outcome. So we're looking basically at actual outcomes and model predicted outcomes based on race. And then we looked at, we compared the variation. And what we saw in all of the models was that for this particular study or problem, is that both the XGBoost and the random forest model, there was less variation as compared to linear model, which basically told us that the relationship between race and our outcome, or our concern prediction, was not linear. And so we ended, we knew that we wanted to use XGBoost. So that was one analysis that we did. We also did another analysis. We were kind of interested. So I mentioned that we look a lot at nursing observations. And so we did another analysis where we basically took the first 24 hours of a patient's stay. And we looked to see if we could build a model, just a generic model, based on nursing observations. And we took all of the nursing observations for patients and we threw in the model and saw it to see if it could predict race. And so you can see here that the boosted model was able to predict race based on the first 24 hours of observations. And we are actually refining this. There are features that we're putting in the model to make it, to adjust for things like the setting that a patient's in, whether it's med-surg or ICU, and also their comorbidities. So we're going to calculate Charlson Comorbidity Index for all of these patients and put it in, and then also what their DRG or their diagnoses, to adjust for those factors as well. And then we'll rerun it. We also we also looked at our scoring before we were adjusting for racial bias, and what this graph shows is, so basically what we did is we took 9,000 patients in our Columbia test data set, randomly took 9,000 patients, and then we predicted their levels, so their concern levels. So this is green, yellow, and red, these three different those three, and then those three different areas here. And then we calculated the proportion of patients by their racial demographics. And we looked at the difference between the proportion of races and the overall concern prediction. And what we found was that for certain races, Asian race, for example, the concern, the outcomes were almost in line with the proportion of race expected. But for white patients, and there was the proportion of predicted was higher than the race, the actual proportion of race, and for Black patients, it was lower. So in our minds, what this meant when we thought about the results was that we're modeling surveillance. And so basically the surveillance for white patients, especially when they end up being red, end up being higher, as you can see, as patients get sicker. And then for Blacks, it's proportionally lower. And so we knew that we needed to adjust for race. And so after we went back and did our adjustments, and we looked at doing adjustments both in the modeling and then also in the post-processing, and that's where we're doing our actual scoring or adjusting our concern levels. We decided to compare, as a validation step, to compare concern to other early warning scores. And so what you can see here is concern, our early warning score, and then the news, or the national early warning score, and the Muse, and these are two widely used early warning scores. And so what we looked at was the outcome of unexpected transfer to the ICU. What we found was that for different races, there was a statistically significant difference between, we just looked at white and Black patients, between the news and the Muse calculation, and there was not a statistically significant difference in the calculation for concern. And so that was validation for us that we actually were able to make that adjustment. And so I mentioned that the last aim was to do the randomized control trial, which we have implemented both here at Columbia and at Partners, or Mass General Brigham now is what they're called. So we implemented our randomized control trial up in Boston first about a year ago. And we were delayed here because of there was an Epic implementation happening here. So we just recently implemented the randomized control trial here at Columbia as well. So we'll be running that for a year, and also for a year, additional year in Boston, and we'll compare our results. And so related to concern, so we are actually planning to apply concern to other settings, inpatient psychiatric, pediatric, emergency medicine, and also rural areas, to understand how those different settings would affect our underlying premise, which is utilizing nursing surveillance as a predictor for risk for deterioration. When we think about monitoring bias and predictive modeling, there is additional work that we need to do. So we plan to look at expected levels of surveillance and outcomes. So the real question is does this matter? Does this difference in surveillance matter for outcomes? I see this difference. I see the racial difference in surveillance levels as missed care. And so the question in the team's mind is does this missed care affect outcomes? We think that it probably does, but the research will tell us the answer. We also plan we'd like to create clinical decision support that's more in real time, looking at difference in surveillance levels. And we plan to submit a NIH-funded grant looking at that, talking to clinicians and understanding more deeply what they might want to know about differences in surveillance levels based on race, ethnicity, and possibly gender in different situations, and where, if that does exist, where in the clinical workflow would they want to get any clinical decision support about that, and what would be the most effective mode or method of clinical decision support to adjust for the levels of nursing surveillance. And so I would be remiss if I didn't thank our wonderful team. It is a multi-site team. There's lots of folks on the team, but everyone's done an amazing job getting from the pulling of data, the translation of data between these two sites, and actually building our implementation and implementing it. So that's all I have. Thank you so much. And I would love to hear if you have any questions.
Yeah, great. Thank you, Dr. Cato, for this great talk, introducing this very interesting. As I will also think could be our life-saving system, like since nurses had like a first-hand experience and real-time surveillance with the patients, and their like, if we can you leverage their knowledge or like their observations of the patients, and create this early warning system, it could really save a lot of lives. With that being said, I open the floor for questions. Do you have questions? Yeah, I saw Katie Brown. Yeah.
Yeah, I see Katie has her hand up. Hi,
Yes.
Katie.
Hi. Yeah, thanks so much for a great talk. Two quick questions. This seems like a really particularly useful in understaffed healthcare settings. So I'm curious if you think this kind of approach will work, even if there are nursing shortages. And then kind of tied to that a little bit is, do you see a difference between newer and more seasoned nurses, either taking the notes or just being assigned to the patient in general?
Yeah, those are two great questions. So the first question, so we actually, there's, in the understaffed setting, we partnered with University of Colorado, Denver. University of Colorado Health System actually covers 5 different states. And they have situations where in some states, in some counties, in some states, they have a hospital that might be 26 beds, and that 26 beds includes pediatric, adults, OB, everything. And they have this concept called a virtual nurse, where they have a nurse maybe sitting in Denver helping the nurses out in a rural county. And so we had planned to implement Concern to help those virtual nurses, but COVID happened, and everyone is still trying to mitigate the effects of COVID. So we do plan to do that work to see how, and the virtual nurse is just one solution to the shortage, but so yeah, we plan to do that. And then remind me your second question, Katie.
Yeah, whether you've seen if nursing seniority or just experience has any effect on if a patient is flagged or not, or how useful.
Yeah. So one of the things that's important to point out about our work is, our work really kind of, and this is true for most work, started very general in the aggregate level. And then we've started going to things like variability in individual nurses. Jessica Schwartz, who's now postdoc at DBMI, has done some work looking at variability in, basically looking at variability in nursing behavior to figure out how we can implement that into our work and into our modeling. What I would say about variability, so the initial work that we've done with variability, both in charting, in documentation, and then also things like medication administration, is that variability probably most likely has to do more with environmental factors, like patient acuity, how busy it is on the floor, how sick and how busy some of the patients that other nurses are taking care of. That affects your care as well, and the time you have with your patients, because you might be called to help them, or people who might usually help you might be too busy. And so so those are some of the concepts that we need to figure out how to model better and include into our model, to make it more specific. But yeah, I think that and also just what we found is that when things do get busy, there's less variability with experienced nurses. I don't know if that makes sense.
Yeah, it does.
Yeah.
Thanks.
Any other questions?
Yeah, I have a question. Can you guys hear me?
Yes,
Yeah.
we can.
Okay. I was having some mic issues before. Thank you so much for your excellent talk, and I really, really appreciated your discussion about the transparency of how concern comes up with its scoring. I think that's really important in any clinical decision support tool. But you had mentioned, I had a question about something you had mentioned where concern or the nursing documentation changes prior to patient decompensation. And you had showed like this, very nice graph showing the concern score change over time. And I was wondering what the lag, if there's like a lag time, how long it is between the concern score changing and, like, for example, medication escalation for a patient, or, the addition of new medications, or
Yeah. No, that's a great question. So that's a great question. We've thought about that. To be honest, in the Concern Project, we have what we like to call an embarrassment of riches when it comes to both data and research questions. We just haven't had the time or the resources to look at that. But we've definitely set up our data set so that we can look at that in the future. We just haven't been able to yet.
Yeah, that you guys have, it seems like you uncovered a lot, so that makes a lot of
sense and one of the things I do have to do a plug for the students that are here. If there's anything, we have a rich data set covering the last 7 years, both here at Columbia and at Mass General Brigham. We basically pull in all of the clinical data, we're except for images. We do have lab data, we're just not using it. And if anybody has research questions that they want to apply to our concerned data set, we'd love to have you join our team. There's just a bunch of questions. As I indicated or alluded to before, what we're really focused on right now is the kind of higher level general question of, do nursing documentation patterns effectively predict deterioration? And we're validating that in the randomized control trial. And so we're kind of locked in to our methods for the next year or so to make sure we rigorously evaluate it. And then we also have data on nursing behavior. So we're logging, when nurses enter into our app, we're logging all of their events, everything they click on. So we will eventually analyze how nurses use our system, and then what happens, what do nurses do after they look at our concern scores and they use our system, and what happens to the patient, what do nurses do, what do other clinicians do, and how is that correlated with how they've used the concern score, and how they've used the concern app. Are there certain behaviors that are correlated or associated with things that'll happen down the line with patients?
Can I jump in? I have a question. Except that I
Yes.
think, Kenrick, thank you so much for the talk, except
Yeah.
that I think you just framed my question as a question. So I'm not sure if there will be an answer. But one thing I'm really wondering is, you know, for you guys in particular, but I think more generally also, in terms of evaluating these kinds of systems that generate predictions, we tend to go from qualitative studies to clinical trials that look at outcomes.
Yeah.
And I wonder if there is a way to, or if you have thought about a way to look specifically at how it changes reasoning, how it changes behaviors on a more than qualitative, in some more systematic, quantitative perhaps way, but less outcomes clinical trial.
Yeah, so we have actually. So so, you know, prediction, I feel like every time I read a paper or look at a presentation about prediction and its performance, there's a little bit of magic that happens, right? When you talk about performance, because it's actually really hard to rigorously evaluate how well your prediction is doing. And so because it is happening in real time, right? And so so one of the things we've thought about is, so if you could imagine that if you could magically go forward in time and look back at a patient stay and look at what happened, then that's really what you want to evaluate from a prediction standpoint. So we actually, we just put in an LLM grant. Sarah is the contact PI. Dave Albers, who's now at University of Colorado, and myself were co-PIs on this grant. And it's actually a methods grant, an LLM grant, to think about. So what we've decided is, because we have levels that we're generating, is to basically create images of a patient stay, and then use methods that do a really good job of processing images, neural network methods to actually evaluate what the patient stay was like from an image perspective, and then computationally evaluate how well the image lines up with outcomes. So that's the way that that's what we've come up with, Lena, so far, with evaluation. We're waiting to find out, but we'll see. We'd love to get the grant and apply those methods to see if that moves the science a little bit further. Does that make sense?
Thank you. Yes.
Is there any other questions?
I have a question or comment.
Yes, Jessica.
Hi, Kenrick. Thanks for this great presentation.
You're welcome.
Great to see you. I guess this is kind of a comment, because this morning we talked about justice and informatics, and Lauren presented on sort of the cascading impact of different decisions throughout the modeling process. And I think that concern is such a good example of making those good decisions and defining the problem from the outset based on a need, rather than just using vital signs because you have them. So I don't know if you want to comment on your approach to that, and how it's so different.
Well, I mean, so one of the things I have to acknowledge is there's a lot that I left out. There's a lot of validation that I left out of the talk, where we, for example, when we were looking at the composite outcome, we spent a lot of time making sure that the outcomes actually are similar, so that it was actually valid to include rapid response with cardiac arrest, for example. So that's one thing. I think also, there's there's typically two ways you come to this problem when you're trying to do modeling. You can either come from a more data-driven approach where you look at, you put in as many features as possible, and then you do kind of dimensionality reduction, and you pick the features that are that kind of help perform prediction as best as possible. One of the, our approach is actually coming from the clinician and talking to clinicians first, and understanding the healthcare process, and the features that help to define that process. And we feel that that's important for a couple of reasons. One is that from a clinical informatics perspective, it doesn't matter if you build the best performing model if clinicians don't use it, right? And so it's got to make the actual interventions got to make clinical sense. And I shouldn't say it has to. We just feel strongly that it should. And it's also got to be interpretable by clinicians, and that's part of it, and making clinical sense. And then also, one of the big things that's come up that I don't know if we've solved this, I don't think this is solved, is the kind of paradigm shift between with clinicians with prediction. So we are predicting an outcome that is not as readily apparent to a clinician based on their training. And what I mean by that is that I think both nurses and physicians were trained similarly, in the sense that if you think something is going to happen to a patient, one of the first things you do is assess the patient. And often you're taught to assess for physiological changes. Because of the type of modeling Concern does, we are Concern's firing before their physiological changes. And so in the whole workflow, we have to convince clinicians to do something before they see evidence that that a change is going to happen. So we try to approach that by having our modeling and our application make clinical sense. Obviously, there's a little bit of user experience that's necessary for them to use it and say, oh yeah, this actually does work. And then we also present some of our evidence from work that we've done previously. But all of that stuff, we just thought a lot about and did a lot of kind of mini studies to think about. And some of that was the topic of Jessica's PhD work, and just a lot of focus group testing and going to clinicians and talking to them. I don't know, Jessica, does that speak to your question?
Yeah, definitely. Thank you.
Thanks for the great discussion. Do we have any more questions?
I have one more question if nobody else has. I don't want to
go ahead.
Take too much. So I have a question about bias.
Mm-hmm.
And again, this is kind of a question for you in the context of your research, but also more general. There's always going to, I think we're more and more realizing there's always going to be an inevitable bias in the data. And yet we still want to make predictions and make the analytics useful for clinicians, because obviously it has value and benefit. How do we balance those two? So if you know that there is inherent bias in the data, what can be done to minimize the impact of that bias on the decisions that are going to be made?
No, I think that's a great question. And, in reality, I mean, that's kind of why at the beginning, I talked about the bias that we leverage in our work. If there wasn't any bias, I can't imagine how you do prediction, right? If the signal was randomly distributed in the data set, then it'd be really hard to do prediction. And so from my perspective, and so I think it's important. I think the most important thing is to understand the bias, basically, and that that when you're talking about healthcare's process modeling, it also, you need to understand the environment and the process, right? I feel like the next step is really to then think about, and what we've thought about is, if we do find bias, one is to try to mitigate that bias in the modeling in the context of the prediction that's important, but then also with racial bias, I mentioned the outcomes. We need to figure out how much, if there is racial bias in levels of nursing surveillance, how much does it actually affect outcomes? And if it does, which there's already science, there's already evidence that says that, you know, difference in clinician behavior does cause disparities. I think that clinical decision support is a great approach to try to mitigate that bias. And so I mentioned before, I see that level of bias in surveillance as missed care, and how can we use clinical decision support to mitigate or reduce that missed care. And that's something that, you know, we're planning to look at more. But that's the, you know, that's kind of how we approach it, Lena. You know, I don't think it's a question of getting rid of bias. It's really first understanding the bias in the modeling, and then if it's important, if that bias is important to mitigate, to try to help mitigate it.
One thing I thought was, thank you. One thing I thought was really curious, how you showed those visualizations where you were kind of examining the bias in this. I'm just wondering, how would it work if this was to be made available to the potential users? If they actually knew what, you know, there is the useful part of it, but there is the bias in it. And then I'm just curious, what would the reaction be?
So that's exactly what we want to do. That's we're going to do future studies to show clinicians that. And I mean, we need to figure out, there's the work that needs to be figured out what's the best way to show them, and how you show them. Obviously, this is all in the context of clinical care. So, you know, we need to figure out how to do it in a way that fits into their clinical workflow, or is something that they're willing to look at some point in their job, and see how we can convey meaning to them, and stuff like that. So that's part of the work that we want to do. That's kind of next steps.
Awesome. Thank you so much.
Thank you.
Thank you. Yeah. As we are approaching the top of the hour, I think we can end our discussion here. Thanks again, Dr. Cato, for this great talk. And yeah, give it a round of applause here. Yeah, I think we can adjourn here. And I'll see you guys.
Thank you so much for your time.
Yeah, thank you. And have a great week. And I'll see you guys next week. Yeah.
Thanks for a great talk.
Thank you.